So this is a follow-up. So this is naturally, screening to diagnostic. But remember, with breast MR, diagnostic indications actually happened first. And so I feel like I have the easier talk because my stuff is not as controversial. So we're going to go and talk about a overview of diagnostic indications. If you're already doing breast MR, hopefully this is just review for you. And then throughout the day, I will delve deeper into any of these topics. So quickly, one of the early indications for breast MRI was axillary metastasis with unknown primary. Now, extent of disease is one of the more controversial topics. Neoadjuvant treatment monitoring, thanks to research, is not as controversial. Nipple discharge is something that we're also using a lot of MR for now, thank goodness, instead of ductograms. And silicone implant evaluation will round out this talk. Okay, so starting with axillary lymphadenopathy, unknown primary. As the name implies, this is where you have a lymph node that is metastatic adenocarcinoma and then you don't have anything on the mammogram or nothing palpable, nothing clinically obvious. So it's unusual. We don't see this that often, less than 1% of our cases. But MRI, as you know, is so sensitive that we are hoping to identify that occult breast primary. It's actually only about 60% good for this. But if you do find that primary, then now you can confidently go towards breast conservation. Otherwise, in some places, patient may actually undergo a mastectomy and whole breast radiation. So some of us these days may consider that slightly over-treatment, but this is why we really want to use our imaging tools to their full advantage. So here's an example, and I had to look hard for this example. This patient presents with an axillary lymph node that's clinically palpable, and the mammogram was negative. Also, the breast ultrasound was negative. Fine needle aspiration of the lymph node showed adenocarcinoma, so we performed the breast MRI. Here it is. So no big surprise. There's a gigantic lymph node there. And this is a level 1 lymph node. It's lateral to pec minor. And here is a finding, a spiculated mass. So this is the primary breast cancer. So we have an ipsilateral spiculated mass that's consistent with the primary breast cancer. We called this a BI-RADS6 known malignancy. Others might choose to call it a BI-RADS5. I think if you're not sure that it's a cancer, then you might even call it a BI-RADS4. But in this case, we were pretty certain that this is the cancer, the primary that goes with that lymph node. And because the lymph node is a biopsy-proven adenocarcinoma, we viewed this as more of an extent of disease evaluation almost. So we did a targeted ultrasound to find the correlate for biopsy. You could also have done an MR biopsy. And this patient did have an invasive cancer and now is a candidate for breast conservation. So let's move on to extent of disease, which is the natural corollary to that first case. So the NCCN guidelines do recommend breast MRI for extent of disease evaluation. And that's because we are finding additional sites of disease that can impact management about 15% of the time. And there is an unsuspected contralateral cancer found in about 4%, 3 to 4%, depending on which studies you read. Now, interestingly, where I am at UCSF, my surgeons feel 4%, some of them may feel 4% is not that high and don't want to do any breast MRs for extent of disease. Others will say, oh my gosh, 4%, that's huge. I don't want to miss that. And then we'll get an MRI on every single newly diagnosed breast cancer patient. So we have, including DCIS, so we have a very wide range of surgical practices still. And I have to say, I've been giving this talk for over 10 years, and it seems like this is still the case. So I don't think that this is going to be resolved anytime soon. You have your believers and your non-believers. Most radiologists do believe in this. For one thing, MRI is really great for determining multifocality, which is multiple sites within a quadrant, and then multitransicity, which is multiple quadrants. So multifocal, multicentric, the residents are always asking, how do you keep them straight? I admit I struggle with this. So the only tip I can give is focal sounds a little smaller maybe than centric. and I think of multicentric like centered in multiple quadrants. So that's the best I can do. And at the end of the day, there's really no BI-RADS police out there. So your eyes will tell you, you know, how big, how bad is it. You show it to your surgeon, and then you all plan the patient's management together. Skin, nipple, and chest wall involvement are important to note because they're going to change the T-stage. Axillary and internal mammary lymph nodes are also important. So internal mammary meaning along the internal mammary vessels, distinguished from intramammary meaning just within the breast, okay? And then obviously you want to look at the contralateral breast. ACR tells us we should be doing bilateral exams. So gone are the days when you just did the index breast. You need to do both breasts when you do your MRIs. This is an example from those early days when we just did one breast. I actually was thinking back, I should try to find a new example, but this is actually from my fellowship days, very, very early days of breast MR. And we had a tumor that they felt was stuck to the chest wall, so they were trying to figure out local extent. So here's the axial and sagittal images, and there's actually a little, let me see if I get the cursor over, there's a little vitamin E capsule on the mass. Let me see if I get this over. There it is. Okay, so that was me as a fellow dutifully taping a vitamin E capsule where the palpable finding is, just in case we didn't know where the cancer was. You know, remember, very early days, 20 plus years ago of MR. So we don't do that anymore. Now we feel pretty confident we can find an enhancing mass, but that's an enhancing mass. And the point I wanted to make is there is enhancement along and into the fibers of the pectoral muscle. So that is what I would consider pectoral muscle invasion, not chest wall invasion. It's not going in between the intercostal muscles and threatening the chest cavity. This is just along the surface of the pectoral muscle, and usually the breast surgeon can handle this, but you just need to point it out so they know. But this explained why the mass was stuck, okay? So this is pectoral muscle invasion, not chest wall invasion. So MRI is more accurate for extent of disease. Here is an example of a woman with very dense breast tissue. There are 2 biopsy clips marking the extent of calcifications, proving disease. So mammography did show these calcifications, which are marked by the clips. MRI showed a mass in addition to extensive non-mass enhancement connecting those 2 clips. Here's a patient with newly diagnosed invasive lobular cancer. Very tricky on mammography and sometimes also tricky at MRI. Luckily for us, in this case, it was avidly enhancing, so that spiculated mass is the newly diagnosed invasive lobular cancer. So we have an upper outer quadrant, spiculated mass. I'm going to point out additional findings. So in real life, you have to look through all of this yourself, but in a conference format, the faculty person conveniently points out the abnormalities to you, okay? You could argue whether that's an abnormality that should be called back or not, but I know we have lectures galore coming up during this course to kind of talk about what thresholds to use, so we won't belabor that point for now, but say this is an actionable finding. It's a suspicious mass, and it's in the outer central breast. It's about 10 centimeters away from the primary. So giving you lots of useful tidbits of information. And the question is, what is the most appropriate BI-RADS assessment? Okay. It's actually BI-RADS 4, suspicious. And if you had questions about that after this course, please come up to us, or during the breaks or at Q&A, we can talk more about this. So just to summarize, for extent of disease evaluations, generally, BI-RADS 6, known biopsy-proven malignancy, is appropriate. And if you're having a patient getting therapy up front, neoadjuvant, either chemo or hormonal or whatever these days, it's also appropriate for follow-up. But if you have a suspicious lesion and it's found in addition to the known primary, and it's going to alter management if it's far away, different quadrant, many centimeters away, this will be relative to breast size, so again, important to work with your surgeon. But if it's going to alter management, then this is a category 4 or a 5 as appropriate, depending on how suspicious you are about the finding. Okay? Axillary nodes on breast MRI. Usually we're doing bilateral axial exams. If you're doing sagittal and you don't feel you're including the axilla very well, then just make sure you have at least one sequence that includes both axilla, and so that you can tell what level of lymphadenopathy you have. Sometimes the right-left phase artifact can obscure the axilla, so you may play with your sequences a little bit and also kind of adjust the patient's arm positioning. In prior years, I've talked about the importance of keeping the arms down by the side, but if they're wrapping into the axilla, you might have them a little bit higher, a little bit lower along their sides. In terms of lymphadenopathy, actually there were some nice scientific papers presented at RSNA about how to evaluate this, but for now, morphologically enlarged nodes, rounded nodes, asymmetry with the contralateral side, so kind of those common sense things. That's what you're going to use for determining axillary lymphadenopathy. So here's just an example of a level 1 axillary lymph node. It's lateral to pectoralis minor. There it is on the coronal, and there's pec minor outlined. Usually we're just looking at these in the axial plane, but I just reformatted in axial, coronal, and sagittal because I could, and also to help illustrate it in different directions in case this is new for you. This is a level 3 lymph node, which is medial to pectoralis minor. All right, there's pectoralis minor outlined on the axial. So MR is a great way to teach trainees the levels because they can see everything all laid out. And then when you get to ultrasound, it makes more sense, I think. So I like to think in 3 dimensions, and as do most radiologists, so having the ability to reformat in multiple planes is also really beneficial. So there's level 2/3. That's because this node is actually bigger than the slice of pec minor that I'm showing you. In any case, it doesn't matter so much. Usually when you dictate these, you say there's levels 1, 2, and 3 lymphadenopathy. What about internal mammary? So IM in this case is not intramammary, but internal mammary. So internal mammary adenopathy, again, morphologically enlarged lymph nodes and nodes on the ipsilateral same side as the known malignancy. Now remember, the mere presence of otherwise normal appearing nodes in the IM chain does not confer malignancy. We looked at this. I had a poor fellow whose eyes were crossed at the end of the year, but she looked at every single normal breast MR we had. We had completely normal MR patients, screening only, no surgery, nothing. And she was able to find and identify internal mammary nodes in about half of those patients. So just seeing the nodes is not a problem, okay? They look like normal nodes, little fatty hilum, cortical, thin cortex. They look like lymph nodes. Those are fine. And you can measure them. They may measure even up to 10 millimeters in long axis. So just seeing the nodes, that's fine. But if they look like this, really big, there's a draining vein and there's a giant cancer nearby, that's an abnormal internal mammary node. Okay, so this is a cancer patient. Here is a normal. So this is an incidental node, high-risk screening indication, and nothing in the breast. Okay? So here's a 22-year-old, newly diagnosed left breast cancer, MRI for extent of disease. And here are some selected slices. Okay, so let me go back. So there is the enhancing mass. And now I'll let you look at the internal mammary chain. Okay, so there's an enhancing mass in the left breast corresponding to the known primary cancer and at a larger mass on the right. So the known was on the left. So this is an unsuspected contralateral breast cancer, okay? So that's the known left. There's a right mass, okay? So this patient underwent bilateral, and her internal mammary chain was okay. So you might have worried a little bit about the plumpness in here, but in real life, you'd scroll up and down, and if you can connect it also, that's another good clue. The vessels will be a tube, right? There'll be a vertical tube. So just scroll back and forth, and if it connects and looks like a tube, it's fine. If you see a dot that comes in and out, that's a node. And then if it's really big and it's on the same side as the cancer, that's when you worry. Okay, so good news, patient was doing well 8 years later. All right, neoadjuvant treatment monitoring. So this is a big thing around my neck of the woods, and that's because of the I-SPY trials. These are multi-center trials of neoadjuvant treatment options, and some of you may even be involved in them, but hopefully you've at least heard of it. So because of I-SPY and the work of my colleague, Dr. Nola Hilton, and many others, breast MRI is considered the imaging study of choice if you're evaluating a response to therapy in locally advanced cancer. It is because it's the most accurate for depicting extent of disease, but probably most importantly, it provides prognostic information. And for our current I-SPY trial now, it is an imaging biomarker. So even here in Florida, when I'm in the parks, I get a text from my research coordinator saying, we have an FTV to sign off because she's pending treatment decision. I sign that off right away. Because even within the trial, we're using MR to decide, do they continue for more chemotherapy, or can they de-escalate, can they stop? So that's the current trial, is testing how much chemo do you need, and can you stop early if they've already achieved a pathologic complete response. So if MR shows an imaging complete response, and if their volume has decreased significantly, then they have this option. Now, we have other things we do in the trial for safety, but the good news here is with this kind of trial design, the patient goes to surgery early. If they do find there is residual disease and they have not achieved a path complete response, then they go on and get the rest of their chemotherapy. So it just puts that last round on hold, and the patients love it. So MR has arrived, and it is here for, at least it's still in research, but we're hoping one day to push this out to the clinic. So Nola is working on making the algorithm open source, and we are hoping to get some grant funding. So if any of you are grant reviewers and you see this grant come through, just know that's what we're trying to do. Anyway, that's a digression. So locally advanced breast cancer is stage 3 disease. It is for large tumors relative to the size of the breast, greater than 5 cm in a large breast, or 3 to 5 cm in a smaller breast. Again, everything is relative. A really large breasted patient who wants conservation could be conserved, and what the surgeons will do is have her see plastics, and then they may do a reduction on the other side to make her look even and symmetric. So any tumor that involves the skin or the chest wall, that would be a T stage 4. Regional adenopathy levels 1, 2, and 3 are important to note, but they are allowed. So you get regional lymph nodes involved, and that is part of locally advanced. You don't want to have distant metastases. So usually on a breast MR, we're not able to assess that, but certainly if you see an enhancing lesion in the bone, you want to mention that, or if you happen to catch a liver metastasis. So on that note, this is a PET CT, but it does include an area that might be included on a breast MR. So I feel it's relevant for the breast MR course. Does the patient have locally advanced breast cancer? And hint, the cancer's on the left. Okay. So that is the challenge, because satisfaction of search, you want to look at that bright hot spot in the breast. But unfortunately, she has a lytic lesion in the spine, which is also avid. So no, this would be stage 4. It just puts her into a different treatment pathway. The rationale for giving neoadjuvant chemotherapy in locally advanced breast cancer, this is where we give it before surgery, as opposed to the traditional way, which is giving it after surgery. The rationale is that we can monitor the response of the primary tumor. So the patient has that satisfaction of not only feeling the mass get smaller, but seeing it. And we do go over the MRs and we show the patients their imaging, even the research scans. The treatment can be altered based on response. As I mentioned, we have a trial paradigm where we alter treatment, but even clinically, the oncologist may change treatment because if the response isn't as brisk as they expect, or even worse, if there's non-response or kind of stable plateau, they may change the treatment options. It is an accepted indication for breast MRI. So although the baseline for prior to neoadjuvant is considered an extent of disease in my mind, if you're saying they're considering neoadjuvant, that usually gets it covered. Okay, so they don't necessarily have to go through it, but it is a baseline for neoadjuvant, and that usually is fine, at least in our neck of the woods. Now, the other nice benefit of doing neoadjuvant is it reduces the size of the primary tumor, and the patient then can become a candidate for lumpectomy. So I mentioned that it provides prognostic information. It also gives the patient time to consider surgical options. So they don't have to rush into deciding what kind of surgery. And in fact, we see this all the time, where the patient initially wants bilateral mastectomies when first diagnosed, and then by the end of treatment, even though they might have been planned for a mastectomy with reconstruction, they'll say, you know what, I actually just want the breast conservation. Less downtime, can get back to work sooner. Or it may happen the other way too. But this allows the patient to really make an informed decision and consider options for surgery. Most importantly, there's no difference in survival compared with surgery followed by chemotherapy. And as mentioned, when pathologic complete response is achieved, we tell the patient, overall, your survival is improved. So it's kind of a good news thing. So here are images from Dr. Ojeda's article in Magnetic Resonance Clinics, which I edited a number of years ago, just showing the baseline scans on the left and then the post-chemo scans on the right. These are MIP images. So here's a giant tumor. We don't see anything. That's what we call a complete imaging response. This one is getting smaller, so it's a partial response. Here, there's not much change. In fact, if you're obsessing over whether disease has really changed, you might as well say there's not much change. So it's essentially stable. Usually it's pretty obvious. And then this one is probably clinically obvious as disease progression. So this is kind of the standard way we use MR for clinical purposes at baseline and then prior to surgery. And it's not rocket science. Here is an extent of disease, newly diagnosed cancer. You can even see the little artifact from the biopsy clip there. And there's some moderate background parenchymal enhancement. And then there is some additional enhancement that is a question. It's always a question, is that background or is it tumor? In this case, we thought it was similar enough to the other side that we just considered it part of the background. This is just to demonstrate how challenging it is to find these things at mammography. There is the biopsy clip, but that tumor was completely masked by dense tissue. So there it is again on MR, pre-chemo, post-chemo, no enhancement on the pre-surgical MRI. So what's the BI-RADS? In this case, it is still 6, known malignancy. So even though you don't see anything anymore, the patient has not yet had definitive surgery. So just remember, while they're on treatment, until they've had their definitive surgery, it remains a 6, okay? So this avoids confusion for the patients and the clinicians. It doesn't impact the outcomes audit. Patient will go on for definitive surgical treatment despite the negative MRI. We are not yet at that stage where imaging is all, okay? Although there, again, at RSNA, folks are doing research biopsies and sampling around the clip, but right now, that's not enough. They still need definitive surgery. Okay, let's close out with how MR can predict response to neoadjuvant chemotherapy. So now this is in terms of research, okay? So we're not clinically using this. It's not in the ACR guidelines or the BI-RADS manual. This is research, but well-documented research at this point. And not that new. So how well does breast MR predict pathologic complete response after neoadjuvant chemotherapy? This is where I show you just the schema for the I-SPY trial. Know that we're doing multiple serial MRIs in this trial. So this is showing MRI at baseline, an early MR, and then a mid-cycle MR, and then one just before surgery. So there's 2 additional MRs at least that are inserted before final MR before surgery. And it's a multi-center trial. It's involving oncology and surgery and radiology and risk prediction folks, these days, it's more of a treatment trial testing out different treatment paradigms. But the original I-SPY trial, I-SPY 1 now, as we call it, looked at traditional chemotherapy, and then we used MR to test its ability to be a biomarker and predict early response. So all the image data was analyzed centrally for I-SPY 1. Now all the individual sites are analyzing their own data. So we measure something called a functional tumor volume. It is not just the enhancing pixels, but they have to meet specific criteria for washout, plateau, or persistence, depending if we're looking at subparts of the FTV. But it's anything meeting a certain threshold criteria for percent enhancement. Empirically, 70%. So this is published. It came out in 2012, so this is more than a decade now of this paper being out. And the bottom line is the change in tumor size measured by MR-FTV was superior to clinical assessment, no surprise. Volume superior to diameters for predicting pathologic outcomes, also no surprise. Interestingly, though, the greatest relative advantage in predictive ability of MR occurs early in treatment. So perhaps a future clinical application may be to add in this early time point breast MRI during treatment. Now, the next question that we asked was, how well does MR predict recurrence-free survival? So using pathologic complete response as a surrogate marker for survival, we already showed that MR did really well. But now, because we have survival outcomes in this prospective trial, we can wait, right, and then decide or look at the recurrence-free survival outcomes. So this is the follow-up paper that was published in 2016, because we looked at 3 years recurrence-free survival, so then you have to give the team time to analyze the data and then get it published. So again, we had the serial MRIs, and volume measurements were advantageous in case of irregular tumor morphology or multifocal disease. MRI turns out to be a stronger predictor of survival than pathologic complete response. So imaging beat out pathology in this research setting, okay? So just as Dr. Monticello was saying that the imaging-based deep learning algorithm that Adam Yala from UC Berkeley now created can predict risk better than all these models. In this case, MRI actually can predict recurrence-free survival better than path complete response. So you know early. And that's why MR is now being used as an imaging biomarker in I-SPY 2 and 2.2, okay? So let's move on to nipple discharge just to close out the diagnostic indications. And I give a whole lecture on neoadjuvant MR, so happy to talk some more with folks. It's a topic I'm very excited about. Okay, bloody nipple discharge. That's significant discharge. No mammo, no sono correlate. We did an MRI. We did not do a ductogram. Haven't done one in years. Yay. There's bright signal in the ducts. Is it enhancing? That's the hardest thing. So here's where I find image subtraction very helpful, and hopefully the patient didn't move on you. So on the subtraction, it looked like there really was a little bit of nodular linear enhancement following the ducts. So recommended MR biopsy. In this case, we didn't bother trying to target an ultrasound here. I thought that's just going to get me a false positive and a lot of frustration. So we went straight to MR biopsy, and in that case, I think it was just some duct ictasia. Sometimes you do get DCIS. And then finally, silicone implant evaluation. So we're leaving BI-RADS territory and contrast, and now talking about implants, which is another one of those early indicators for breast MRI to evaluate implants, but the protocol is different. We don't give contrast. We say that this is not a cancer evaluation, so there's no confusion. In fact, we dictate these separately and we don't assign a BI-RADS. Okay, so no BI-RADS if you didn't give contrast. This patient had chest trauma and a rib fracture, so pretty significant chest trauma. The implant, no surprise. You can see that the lines are all wavy and flat linguini. So this is the classic linguini sign. It's an oldie but goodie because usually they don't see them quite this ruptured. So this is silicone implant rupture. And by the way, if there is a syllabus, this is not a FSE, this is a STIR. Sorry, my bad. So I'll correct that for the future. Intracapsular rupture, that is defined as the rupture of the elastomer shell. So the implant, the silicone is contained in this elastomer shell, and when that shell breaks, that's what gets the Linguini sign. With intracapsular rupture, the silicone is still contained by the fibrous capsule that the body makes. So the fibrous capsule is that dark outline that you'll see on the T1s. And when the silicone goes outside of that fibrous capsule, as in this image that comes from AJR, it's also kind of blobby. That's extracapsular rupture. So again, that can be a whole lecture in and of itself, but just a quick overview of all the diagnostic indications for breast MRI, from cancer indications, which are the majority, all the way down to silicone implant evaluation. And with that, I want to thank you for your attention.